السلام عليكم. إن شاء الله جميعا تكونوا بخير وأحسن حال وموفقين جميعا. خليني ابتدي معاكم كده النهارده الاورينتيشن، وفي نفس الوقت هي جزء من الفاينل ليكتشر للمجموعة اللي كانوا معانا. إن شاء الله بالتوفيق لهم جميعا في الامتحانات والأجواء اللي يعيشوها. We should start إن شاء الله to make a quick كده revision for the exam of last exam I gave to you. يلا بالتوفيق لكم. أظن كده معظم الناس اللي كانت موجودة دخلت. أتأكد بس. أوكي. في مشكلة في الفويس. في مشكلة في الفويس. اوكي. جود. ريدي. let's start. خلي الاورينتيشن في الاخر، يعني in the end start ان شاء الله الكيسز فيرست معاكم الاكزام اللي احنا اتكلمنا عليه على الجروب. بسم الله الرحمن الرحيم. let's go. So this case, this patient, if he comes to you in the exam, maybe he will ask you to point by a marker. هيقول لك كده في الامتحان point the abnormality with marker. So what you are going to do? Anyone have marker? So where is exactly you'd like to describe? هنا في ال EDIR مختلف شوية. خلينا امبارح كنا بنتكلم على ال FR، هنا النهارده EDIR مختلفة شوية. is يعني more like active exam. هو كله بيكون digital on the يعني البي سي او الكمبيوتر عندك، ويكون digital exam بتتفاعل مع الشاشة. So he will ask you to point, give you marker كده، وايه تحط الماركر على مكان الابنورماليتي. So if someone want to chat to say the location, is it femoral, is it in the iliac bone, where is the abnormality here? And sometimes he give you like more than view and waiting you to give any explanation. After you mark the lesion, I am waiting for someone to mark the lesion or to mention where is the lesion. Yes, Dr. Agada, you can join in the chat if you can mark it. Dr. Sandy, our stars before. So where exactly you can mark the lesion? Upper femoral, lower femoral, upper iliac. Okay, so where is the lesion here? We will wait for you to mark, then describe how you can describe this lesion. Someone figure where is it? Where is it? So let's go to the next. Better no voice by chat. Okay, so anyone can agree with me that there is something here? Okay, excellent. So what you will do next for this patient? He will ask you in the exam what you will do next in this lesion. حل الامتحان ده عارف الايه قالوا له ايه ساعتها. طيب, so what is next? You like to figure out what is here, so maybe you can take extra views. So this patient, maybe you can show it more clearly that there is endosteal scalloping here. Everyone agree? There is lesion here. So we are sure now about the lesion. This patient have knee replacement. In this case, what you will do, let's go to the next. Yes. They do for him CT. هنا he will ask you how to describe the lesion. هنا ممكن يطلب منك notes. lytic lesion. Okay, sharp demarcation or hazy demarcation. Sharp demarcation or hazy demarcation. So also you can note the fat density here is maintained. Anyone have suggestion for this lesion? What could be the differential? Excellent, Wael. This is typical appearance something. I see that Ghada already ordered, Sandy ordered MRI. So this is the MRI. This is T1 MRI and coronal stair. T1 with fat set. So when you describe this lesion, be careful ان انت تتكلم عليها في description. How to describe this lesion? If you note that the marrow signal inside is preserved, which is against حاجات كتير زي against ايه؟ against الميتاستاسيس, against المالتيبل myeloma, صح؟ بيكون فيها infiltration. هنا there is no infiltration. Then you can suggest, as I see, Wael Islam, perfect. So this patient could have what is called Paget disease. What he will do for you, he will ask you for next step. What you will do next step. انت الان في الاكزام هو بالظبط بيكون ديجيتال, بس بدل ما انا بتكلم الشاشه هي اللي بتتكلم. اوكي. So what you will do next? Nuclear. So which type of nuclear scan you would like? Well, perfect. We'll do bone scan. Why? You want to see if there is many lesions or one lesion. So what is called polystotic or monostotic lesions. So this patient have Paget disease. Excellent. So this is the typical appearance of Paget. One of these cases. طبعا Paget, maybe he can ask you about complications in Paget. من اشهر الكومبليكيشن لو عيان جاي لك في acute stage ممكن يجي لك fractures. Okay. طيب, let's go to the next case in the exam. Who solved the exam? He saw it before. Let's go. Okay. So where is the lesion and how we describe it? Okay. So right shoulder, right scapula. Lesion where? Better شيرين systematic. خلينا زي ما تعودنا شيرين systematic. Describe first, then give differential diagnosis, then finally inshallah you will get the best mark if you did these steps. So you agree with me that there is a lesion? Yes, there is a lesion. So where exactly it is located? Everyone agree that could be located in the You need other view to get localization better. Let's see. So this is the other view. AB. Okay. So where is the lesion? Scapula. Okay, scapula. Spine. Where is the spine? In the spine of scapula. Everyone agree with this? So better to go back to the Y view. We can agree now. Okay. So how we describe this lesion? You mentioned that there is a lesion in the spine of scapula. So is it like benign looking lesion or aggressive looking lesion? There is destruction or no destruction? Yes or no? Benign looking. There is a fracture or no fracture? So هو هو بيعلم في الإكزام هو بيكون he will be careful about these two descriptive items if you will comment in this. So destructive lesion, yes, bravo, Islam, and then there is pathological fracture or no, at least you will think about it, okay? At least you are suspected that this patient have pathological fracture. Then the next step, what you will do next? Okay, what you'll do next? MRI, excellent explanation. For some reason, they did CT. So let's see if they are wrong or they are correct in choosing CT. And everyone now will tell us if they are okay that they choose the CT or not. Let's see. This patient did this CT, which is selected images, and did someone pick up any abnormality in these images? If you say yes, so please tell me where the location of this abnormalities. We'll test with you the most fast star today from our stars who can pick up the abnormality quickly. So let's see. I am showing you all the cuts, and I know that some of you have like eagle's eye, so we can pick up all the abnormalities quickly, which is the exam style. So someone, yes, Sandy, bravo. So there is lesion in segment 6, excellent. Segment 6, at least, yeah. And do you agree that there is something here? Maybe? Yes. So there is lymphadenopathy, abdominal lymphadenopathy. There is atherosclerotic changes, which is maybe something not related to our main disease, but we have to mention it. Anything else? So patient have a scapular lesion, which we saw it before, destructive lesion. So when you comment in this, how we describe? هنا بتجمع درجات, you will get marks. How we describe the lesion? When you describe something, you have to be careful in your description, short but to the point. You will describe something, but you have to be to the point. What you describe is very limited words because you don't have much time in the exam, but in the same time, you have to be to the point. So I will see the best description right now. So what is the best description? Best description in this case. Okay, destructive lesion, slam. Soft tissue lesion, destruction of right scapula, excellent. So let's see. Destructive lesion, okay, excellent. Extraosseous soft tissue, Shireen, excellent, better. I give you better mark for this. When you describe the soft tissue as well as in this lesion, it will give you that you are aware with these lesions. Aware how to describe well such lesion with aggressive malignant looking behavior. So let's go to next question. What is your next step? Now you get something in the liver, something in the scapula. So what is next step? Let's see, someone will agree with this next step or not. They did bone scan. They start to feel that is malignant. Do you agree that this patient, should we search for bone metastasis or not? Okay, so do you think that this patient have metastasis or neoplastic lesion or not? Someone mentioned that it could be in the right scapula. I can imagine that you like to say like this. So you agree? Okay. Excellent. Anything else? Someone will talk about this appearance in the ribs, which is linear appearance. I think this one will be fracture site. Anyway, this patient, they did for him ultrasound. And finally, they take biopsy from the scapula and should prove that this patient is malignant. Which type of malignancy? Anyway, this was bone metastasis from squamous cell carcinoma. So this is how they deal with the cases. They discuss you in a way that you will see. I will delete this case شوية. Okay, let's take this case first. Okay. Some of the cases, when you go to the exam, you will find that is a bit short. They like to choose, like they give you some choices and you have to select, or maybe like this case, it would be like a spotting or anti-mini case. So what do you think about this case? One selected image, and just you have to say what it could be. So what do you think? Anybody want to comment on this? Who will be the first? Okay, excellent. Dina. Excellent, excellent. Bravo. So this is what is called sigmoid volvulus. Sigmoid colon is grossly distended. Yes, this is the typical appearance for sigmoid volvulus, which is critical and surgical emergency. This is a surgical emergency. Excellent. So this type of cases that just it is one diagnosis, like one diagnosis. You have to be like one shot to mention what it could be. Sometimes they can give you like some answers and you check what it could be. So let's go to the next case. This patient did this radiograph for the pelvis. So someone can think what it could be. I will just delay this case. I know that it wasn't the exam, but I will delay it for a while. We can come back. I just want to show you this first. Sorry. Let's go and see. By the way, the exam, I mean the exam what I give to the group, not the exam in the reality, to be sure that everyone understand well. Okay, so what do you think? How to describe this lesion? And what is your differential diagnosis? What is your differential diagnosis? So if I will give you like a key in this case, take care from the age. If you go to check any lesion in the bone, before you start to comment, take care of the age. If you find that this patient is pediatric age group, so be careful that you will go to choose something which is fitting this age group. So for example, some of mention in the chat something which is not in the in this age group, so I cannot put in the differential diagnosis. Okay, infection is a good differential. Excellent. So this is osteolytic. Excellent, Shireen. Osteolytic diaphyseal lesion with wide zone of transition and periosteal reaction, which is look like a bit aggressive. You agree with me? Yes. So aggressive periosteal reaction. Onion peel, right? Okay, so either infection, Ewing sarcoma, Dina, perfect. So just you are missing one of them. I need just to add another differential diagnosis which fitting the age of this patient. Someone can, who will know this differential diagnosis? Yes, could be metastasis, excellent, could be osteomyelitis, Ewing sarcoma, but is an older age group. We need something that fit this patient. Someone can help me. Who will be our big star today to reach this? Yes, Dina, perfect. So this is what is called eosinophilic granuloma or Langerhans cell histiocytosis. Perfect. When you go to one case like this, and they can give you this like a short case or long case. If it come to you like a core case in the EDIR, and probably they will ask you to point the abnormality, everyone will be agree with me that this is the lesion, this is the abnormality, which is what? What is this? This is lymphadenopathy. Yes, perfect. So this is lymphadenopathy. So the next step, what it will be? What you expect? Yes, someone mentioned that it could be lymphoma, which is excellent differential diagnosis. Perfect. Anyone can add anything else. And I will ask you what you will do next for this patient. If I ask you what you will do next for this patient, what you will do next for this patient. Histopathology is good option, but still you need before to go to biopsy to at least to limit differential diagnosis. So lymphoma is still a good differential, and all things that make lymphadenopathy as a primary. Yes. So could be secondary. Do you think that this lesion could be a secondary? I mean, metastasis lymphadenopathy. Yes, it could be. If I ask you what type of metastatic lymphadenopathy you would like to investigate, if you saw para-aortic lymphadenopathy, they will ask you for the MRQ, the MCQ, and for the current situation. Yes, it is, Shireen, perfect. So in the next step that I will go like to check for any inguinal, any scrotal tumor, which come in the germ cell tumor in the testis, like seminoma, germ cell tumor. So ultrasound scrotal, yes, good option. So this patient, exactly what he did ultrasound for him, and imagine what they found. They found the seminoma, the reason for what he had. So this is one of the common type exam questions that they ask you about how you can think in the differential diagnosis. So let's go to the next case and ask you, what do you see in this patient? Before you start, when you comment in any film, in any radiograph, just be careful of the age of the patient. So when you choose something, as we mentioned before, you have to choose something that fitting this radiograph. Okay. So good description. Shireen, good description. Slam, perfect answer. Thank you. Large soft tissue tumefaction displacing the bowel loops. Excellent. So exactly what we have. So then the question he will ask you again, what you will do next. And when he asks you about next step, which is a usual exam question, take care of this. You should be specific what you will do for this patient. What you will do for this patient. So take care, Slam. You get stuck in the, which is, yeah. Someone will ask you, we can do in pediatric CT, yes, but very limited. Like we have to weight the risk and benefit. This patient, you expose him to radiation. So when you expose him to radiation, you have to be careful. Why and why. You ask يعني yourself, هتسأل نفسك كده عدة مرات. ليه أعرض الطفل ده للراديشن? When I have more easier tools I can use. So someone I can see, Shireen, ask about ultrasound. So let's see what ultrasound can give us. We did, and we find that there is a bowel dilatation and there is soft tissue tumefaction in one region, which is left paracolic region. Then we do specific ultrasound to check for this region. So someone, I think he will be happy to describe what is going on. Yes, Islam, excellent. So take care in the pediatric age group. When you ask for CT, yes, you can ask. But when you ask for CT, you have to be careful why you ask it. If you find another tool that can help you in the differential or can help you in the diagnosis, so you have to choose the more safe tool for this patient. So this patient have intussusception. Everyone agree? Everyone agree with intussusception? So, okay, perfect. So then when you comment about intussusception, still you are missing something. I can see this thing in the image. And when you comment that it could be intussusception and you didn't mention this, yes, perfect. So this is the free fluid. When you didn't mention it, you will lose some marks. So take care about this. So then the question will be, what is your next step? Again. So this is how the way when you deal with the EDIR cases, it is like you are in active practical cases. So you have, I will mention after a while, the orientation. So when you will go to orientation, the next half of this lecture, you will find that how we will deal with the core exam. So this is the core type of exams, exam cases. So free fluid, yes. So which type of reduction you choose? Shireen, she chose that she will go with air. Excellent. Air reduction. So let's go to the air reduction. They will ask you about details, pressure, how much pressure you, mercury, millimeter mercury, how much you can reach. Perfect, Shireen, 120. So therapeutic air enema was performed. And what do you see now? This patient resolved or not? Let's see together. You see what happened here? In the left paracolic gutter, then yes, finally, this patient, yes, resolved it. Yes, so this patient now he is resolved. So reduce, there is reduction with success. Intussusception, one of the common exam cases in pediatric. When you go to the pediatric and you find that this case was intussusception, you remember me. Intussusception, one of the most common scenarios in practical cases, in pediatric, and in the exam cases. Reduction, one of the questions that's asked like very frequently these days. So we saw target sign, pseudo kidney sign, crescent sign. Take care about the free fluid. You have to comment about the free fluid, and there is any absent blood flow when you comment about the ultrasound. Okay. And finally, the reduction as we talk about the treatment options. Okay. So let's go to another case. Someone tell that about the types of reduction, that there is a debate which one we choose. Is it like hydrostatic? Is it like okay, air reduction? Okay, today I am fixed with how we deal with the EDIR cases. I give to the group some cases, and they already solved it, but we try just to discuss how we can deal with it. So if I show you this selected image of another patient, who is adult patient, and maybe you can agree with me that there is something wrong going in this patient. So what could be this wrong thing? Yes, someone note that there is something like fat density. Excellent. So there is multiple fat density lesions. Yes, exactly. This is what is going on. So Islam, yes, I can see that most active stars today, Islam, Shireen, and Dina. Yes, perfect. So yes, so there is intussusception. One of these lipomas make like degree of interception. So it can happen in the adult group as well. Yes, can happen. Then let's go to another case, which is a bit difficult case, but we'll try to with this group, which is active group. Let's see what they can how they can deal with this case. So they give you this patient who have like chest pain in the left side and he have much cough. So anyone can pick up where is the abnormality. Anyone can participate, anyone can join us, anyone can write in the chat. I will encourage everyone to join us, even if you can mention anything. This is just discussion, some discussion before we go to the orientation to the new group, inshallah. So if we go think about what is going on, there is elevation of the left diaphragm, excellent. There is abnormal lesion in the left hilum, excellent, and parahilar region, yes. So then the question will be, what you will do next for this patient? You agree that there is something abnormal. Then here we can go to the CT direct, yes. So when you go to the CT and you saw this selected images, what do you think? This is the lung window. So if you get like some selected images like this, then you have tool in the exam that you can change the window. Yes, it is finger and glove. So when you change the window, you have anything in your mind that give you excellent differential? Yes, I can see that this hypodense areas could represent what? Could represent what is inside here. What makes this patient feel like he is, yes, what is called bronchocele. And this bronchocele form from what? Dilated bronchi, bronchioles, yes. What is called allergic bronchopulmonary aspergillosis. So this is happen when there is mucus plugging. In the MCQ, they like to ask you about this and the place. Usually it is in the upper lobe. So bronchiectasis, bronchoectatic changes with dilated bronchi, and what happened here is mucus plugging. Excellent. So let's go to another tricky case. I think is a bit difficult, but let's start. I see that we have nice group. So let's start. What could be abnormal in this patient? Any abnormality in this patient? This patient came with acute chest pain. Acute chest pain. So when he gave you something in the history, when he asked you about the next step, you should be specific what you will do. And if you saw abnormality already or not. If in the exams in the exam they sometimes give you like the lateral and AB like a small picture up, so you have to choose and to check both of them. Don't check only the AB or only the lateral. You have to check both of them. Okay, so maybe you can find something. So anyone note anything abnormal? I know that maybe the quality of sometimes, especially the internet, is a bit hazy, but someone can note with me something here. Let's try to draw it. So do you see this abnormal, like ovoid shape something? Can anyone saw it? if you saw it, just mention in the chat that yes, please. Anyone can mention. There is something here, like rounded. Yes, perfect. So if someone saw it, so this means the resolution is okay. Yes, very faint, very, very faint. I agree with you. So now this patient came with acute chest pain. Don't forget the history. Yes. Excellent differential. You are worried about aneurysm in the ventricle, but do you agree with me that usually we saw the ventricular aneurysm in this side beside the left ventricle, right? Which is a common side. And this patient has sternotomy suture. So you need something, right? So what is your next step? My question for you now, what is the next step for this patient? You will ask him to go home or to do something. What will be this something? Cardiac CT, excellent. So let's see. Let's see if we saw the selected images. Someone can help us, who is experienced in cardiac CT. He can help us. What we have here. Yes. What we have here in this patient. 10 stars for someone who, yes, Shireen, you have the 10 stars, mashallah. So this patient have like aneurysm. Yes, aneurysm. So if I ask you which branch of this is the right coronary artery, come out from the right aortic sinus. So when you go to in this area, you'll find that there is large aneurysmic dilatation of the right coronary artery. Excellent. So this patient have coronary artery aneurysm. And do you think that this is something critical or not? Yes, it is very critical. So this patient already, when you describe this aneurysm, you will get marks, but still you have missing marks. Some missing marks. Why? Because when you comment in this lesion, you have to mention something. Yes, this patient have something mural. It could be mural hematoma or it could be thrombus. Okay, so you have to confirm by non-contrast first. Anyway, at least you have to mention that there is a crescent lesion around. In this case was thrombosis. But I mean, in general, you have to check the pre-contrast to be sure that this patient don't have hematoma. But excellent, you get it. You get the full mark here.
ممكن نفرق ازاي يا فندم ما بين الهيماتوما والثرومبس؟ ممكن حضرتك تذكر افرق ازاي ميورال ثرومبس والهيماتوما؟
Okay.
Okay.
Pre-contrast. You have to check the pre-contrast. If you find the pre-contrast, there is crescent hyperdensity. So probably this is hematoma. And also they have many things, not just this one. But quickly, the scope of this session is to talk about the EDIR exam cases, how to deal with it. But I think there is some other differences other than the pre-contrast. But anyway, let's talk it inshallah يعني, in another way. ماشي? Yes, so the final diagnosis in this case was RCA aneurysm with giant aneurysm with thrombosis, partial thrombosis. Yes. So let's go to take like a break for 1 minute, and then we continue. No moving. No, don't move. Just in your place, in your side. Okay. So after I will show you some cases in this session, I will go finally to the orientation of the new course, inshallah. But we want to finish as much as we can with these cases. So if something like this come to you in the short cases, then he will ask you about the description again. How to describe this lesion and what you will do next. This patient have hand pain. So if you have hand pain, yes, lace-like appearance, honeycombing appearance, trabecular pattern. Excellent descriptions. Okay, so in these fingers, and this metacarpal and this phalanges. So you are worried about sarcoidosis. Excellent. What you will do next? Maybe he will show you chest X-ray or maybe CT chest and ask you about the description. So this is typical case of sarcoidosis. Let's go to another case of neuro case, long case. So this patient came with this appearance. How do you comment? What exactly your comment? Someone, yes, posterior, Dina, perfect. So there was posterior fossa mass, but we don't see the mass right now, right? You agree with me that there is something like clips here, surgical clips. So this patient have previous tumor. Someone, excellent. This slit-like appearance. She mentioned that this patient have what is called overshunting. How you can prove this? Do you have any other proofs or signs that can support your diagnosis? In these two selected images, SLAM, excellent. Hypotension, yes, the other name is hypotension syndrome. So how you can select or prove that this is hypotension or overshunting? Yes, there is hyperdensity in the anatomical site of the transverse and sigmoid sinus. So what is called distension of the venous sinus. He might show you the previous study, he might. And when you go to the previous study, you'll find that this patient had the same shunt, but he wasn't have anything in the sinuses. And he was having the same surgical clips. So current situation that this patient have what's called hypotension syndrome or CSF overshunting. Excellent. So this is another type of exam cases that come to you like something post-operative, and he don't want you to say that this patient had posterior fossa tumor. He want to know the complication happened after the intervention right now. Okay, excellent, Mina. Yes, bravo. So let's see what this patient have. Another patient. If I ask you what make you to think that this patient have abnormality, before we scroll, what in the first image here, something make you to feel that this patient have abnormality? Yes, excellent. So this patient have proptosis. So we are going to something abnormal, need to investigate what it could be. So let's go to the selected images together and find what he have in this patient. Excellent, proptosis, yes. So this patient have this appearance. What you will do next? How describe this lesion? So I can see that Samir, yes, this patient could have subperiosteal abscess, excellent, with extension. Yes. What else? So this patient have left orbital abscess, proptosis, and facial swelling, edema. So the extension come from sinusitis. Bravo. Shireen, bravo. Islam, yes. So this patient did with contrast, as you mentioned. In the same setting, we inject him contrast to see the characterization more. Okay, so this patient, what is your final diagnosis in this patient? I will go show you corona again, but in bone window. So, yes, sinusitis. Density of this sinusitis somehow has hyperdense. Do you agree? Yes, Samir, perfect. So this patient could be one of the types which is called invasive fungal sinusitis. Why invasive? Extension to the orbit. And what you are worried about now, if I mention orbital extension, what the other extension that you have to comment either by positive or negative? Excellent, Shireen. So we have to comment in the intracranial extension, which is very common to happen. This is a difficult case I will show you right now, but I know that someone here, we have much stars. So this patient, pediatric age group again, and you can see what he have. What do you think? You have deformity. Excellent, deformity. One side, two sides, many sides. What you will do next? You make the pelvis and you find this two deformities. Wael, Shireen, Dina, so we are worried about fibrous dysplasia, one of the entity that can cause this type of deformity, shivered crop deformity. Yes, abnormal remodeling, bowing. So this is how we describe bilateral femur bowing, yes, and remodeling. And the most important, when you describe this, to comment in something here, which gave you the key for this case. Yes, the ground glass density, ground glass density. Yes, ground glass matrix. Then you can think about fibrous dysplasia. So do you agree with me that we have to continue the skeletal survey? Maybe find more? Yes, maybe we find more. This is what's called polystotic fibrous dysplasia. The next step will be, he will ask you about the syndromatic disease that happen in this type of polystotic. You have to check in the literature. They like it in the exam much, like they have many questions about this type. McConnell-Bright or Maza-Brown disease or others even. So one of the most common exam cases, fibrous dysplasia. I see that everyone is like start to be tired. So let's go to the orientation or we continue. We still have some cases. We'll make like voting. Okay. Okay. Let's continue for a while, then go to the orientation. So this one of the common cases that even come to the practice, but it again is an exam case. And when you scroll down or up, you will find this appearance. It have many criteria. And when you go to check the sagittal view, maybe you will note something. So finding of this appearance, there is expanding for the dural sheath around the optic nerves on both sides. And there is what is called partial empty cella. So you be worried about something, and what is your next step? Increased intracranial tension, yes, eye drops, pseudotumor cerebri. All this is the name of this tumor is what is called idiopathic intracranial hypertension. So today we mentioned the hypotension, and this is the hypertension. This patient need something from the ophthalmology. He need to consult the ophthalmologist. What you will ask the ophthalmology to do? He need to check for what? Fundus examination, excellent way. Optic nerve, you want to check for papilledema. Another case which is a bit difficult, more difficult, is not common in case exam, but I will show you. So we have T1 and T2 for these selected images. You can imagine what happened in this patient. And he already have this prosthesis. What's the name of this? And why have this prosthesis? So this patient have this. What is this? We mentioned it in another case. Yes. So this is the VB shunt. Shunt. Yes. This is a shunt. Yeah. And this patient have hydrocephalus. So this is critical case. This patient have to be shunted. So we shunt him. So now let's see what is the cause of this. We have something here. When you go to check the T1 and T2, so we have something here. What it could be? Okay, I like your answer. So we need other sequences. We need other sequences. Excellent. So when we go to the diffusion, it look like this. We need diffusion, yes. We need post contrast even. And this is the flare images. So somehow this patient, he don't have anything in the diffusion here. That's mean what? That's the importance that when you check for the sequences, you have to check all the sequences, not to check for some images, then give diagnosis. Yes. So when we talk about the differential diagnosis, this is intraventricular lesion here. This intraventricular lesion don't have any diffusion restriction. So we talking about arachnoid cyst, any type of cyst. Yes, that's a good differential diagnosis. And when you check the T2, you'll find something like artifact. And this artifact is still going on in the flare. And even the T2. This is something differential, I'm sure, but it's called trapped ventricle. It's called trapped ventricle. Yes. So this is like a CSF, but trapped ventricle. This is the diagnosis. Just write this in the Google and you'll find something about this trapped fourth ventricle. Exactly, this is the diagnosis. This patient is a female patient. As you see, she have breast and they have a chronic cough. How you comment in this lesion or these lesions? So there is bilateral lesions. Yes, bilateral lesions look like reticular changes. Yes, bilateral reticular changes. Reticulonodular changes, okay. So start to think about the differential. But before we go to the differential, is a good issue that you think about the predominance. Is it like upper loop predominance? You agree with me that this reticulation are more in the upper loops? Then you have to think about, let me try to help you. If I make like a line here between upper and lower zones, so do you think that is more in the upper region? Could be yes. Then now you have to characterize more to think about something that can happen in the upper loop. Okay. So when you give a differential diagnosis, you will put sarcoidosis one of this differential. Then the next question will be, what's the stage of, if you mentioned that this is a sarcoidosis, what it could be the staging here? Can you stage the sarcoidosis from radiograph? Yes, we can. So everyone agree with the stage 2? Sometimes it's difficult. So if you cannot, yeah, I think it's more going with the stage 3. Yes, I think more going with stage 3. Yes, so this was a case of sarcoidosis. But I sure that the differential, you need to check the CT, as I will show you, but this patient have already lymphadenopathy. Yes. Yeah, this is one of the common cases. I am going to show you another case right now before we go to the orientation. Someone which is difficult case, someone can pick up where is the pathology in this case. Yes, perfect. So we can see clearly that there is, if you try to trace the rings of the pelvis, which is a routine check for the rings in the pelvis, as you know, this is the checklist in the pelvis. You have to check the rings, and this all the pelvis are like rings. So when you go to check the rings, you will find that there is something here. Okay, so if you agree with me that there is something here in the right acetabulum, I think you're right to investigate what it could be. So let's go to the other views to check what it could be, this patient. Then what could be the next? Check the clinical of this patient. Anyone have suggestion what could be differential in this case? Anyone have differential? What could be? While you check in the other images, you find that this patient have hand X-ray. So this is the importance you can link. Some of these cases, exam cases, is linked between many abnormalities. Ground tumors, excellent. Acrohistolysis, patient hyperbara with brown tumors in the pelvis. Okay, so this is the hyperpara with brown tumors. Okay, excellent. One of the cases, and this is like become like something like in the exams now. Yes, there is resorption of the terminal tuft. Yes, that you have this selected images, and this patient came with some clinical data. Denoting that this patient have something in the temporal. So what is your differential? This is the T1 and T2. What you will do next? Yeah, there is something left hippocampal. Excellent. Contrast. So this was the contrast. There is no contrast enhancement. Do you agree? No contrast enhancement. So when you describe in this case as a long case, you will think that there is no enhancement, no significant enhancement. What other sequences you'd like to check in this patient? Someone mentioned that it could be herpes. So if you mention herpes, what is the best sequence you'd like to check? Okay, diffusion. So this patient has some restriction. So what is your next step? What you are thinking about? Anything apart from herpetic? This patient, they did for him this study, and they find this uptake. Do you know what is this study? Yeah, they did him something called FDG, PET-CT, yes. Fluorodeoxyglucose, PET-CT, yes. So if they make this study, do you think that there is any benefit that this lesion have high metabolic activity in this study? So what is your differential right now? In this type of cases right now, they involve a lot of PET-CT, a lot of PET-CT or hybrid, you call it hybrid imaging. So yes. So either primary glioma or secondary metastasis. But do you think that the glioma have typical appearance like this in the MRI? We saw the MRI before. Do you agree with me that this is not typical for glioma? Yeah, maybe low grade, but when it take high activity in the PET-CT, this means that is not low grade, it's high metabolically active lesion. So if you did PET-CT, please continue to do for the whole body. This is the advice for you. So when you go the whole body PET image, you will find that there is something here. What could be this one? It's lesion. Where is this lesion? In the chest. Yes, agree. Everyone agree? Chest. Yes. So where exactly? The chest, mediastinum, or in the lung, or in the lymph node? Do you agree with me that I would like to check the selected CT of the PET-CT? So when I go to the CT portion of the PET, I found that there is lesion here. What do you think? What is your final diagnosis about the MRI? Let's go to the first case, first image, sorry. So this lesion, what it could be? Metastasis or limbic encephalitis or paraneoplastic disease? Yes, this was paraneoplastic, what is called limbic encephalitis. So the teaching point from this, that yes, limbic encephalitis can look like a metastasis. Still, you can put glioma, gliomatosis cerebri, even metastasis, even herpetic. All this can be in differential diagnosis. Now, time for orientation. This is the orientation. I'll just make something now.